The role of biomechanics is increasing slowly in the field of cornea and refractive surgery. We have now realized that before the structural changes actually set in the cornea, the biomechanics have already been deranged for too long. It sort of works a bit like glaucoma, where if you have changes in the visual field, you probably have lost most of the nerve fiber layer. We are trying to incorporate the use of corneal biomechanics in our daily practice. We use these in patients before refractive surgery. And really the most important uses in patients which they sit on the fence. Pentacam is fantastic. It serves for most of the cases. We are able to tell, well, this Pentacam is good, this Pentacam is not good at all. There are cases when the D values are really borderline, they light up as yellow. In those cases, the Corvis works very well for us. So with the new entities, Corvis Biomechanical Index, it has become really easy for us to screen out these cases. Now, the difficult question sometimes is whether we reject these patients. We don't do refractive surgery. Well, it depends on patient to patient. If a patient has got borderline D value and sort of borderline CBI on Corvis, we might repeat that in 3 to 6 months, depending on the age of the patient, the amount of refractive error. So it really depends. But we now know that there's an additional thing that we have, which is Corvis, which can give us an idea about the biomechanical strength of the cornea. So it's pretty handy, I would say, and we really hope that the unit becomes better. We have more objective measurements, and that's going to happen if more people use it in different parts of the world. So we use it quite a bit in Asia. So we had a unit in Hong Kong. There are quite a few units in China as well, but we need more data from the rest of the world. It is very important to generate normative data for any new machine. And as I just mentioned, there's a lack of normative data. Most of the data that we have is from Asia and Asia Pacific region. There is some data available from the United States as well, and now we are generating quite a bit of data from the University of Pittsburgh Eye Center. Unless we have, as I just mentioned, a huge amount of normative data, it's sort of always challenging to tell normal from abnormal. So in initial publications on Corvis, there was a cutoff point of 0.5, for example, where we used to divide normal from abnormal eyes. But as you look at more data from different eyes, Asian eyes are quite different from Caucasian eyes, we might need to change those numbers, we might need to make an adjustment to that. So it's very important to collect as much normative data as we can. Initial papers on repeatability and reproducibility of Corvis parameters, they're very, very encouraging. And we really hope that this is the case from the rest of the world as well. That was really interesting. We expected that. So it's important to understand form first is a very special kind of condition. Here's a patient population which we know has keratoconus, but has not manifested either clinically or on tomography. So we know that biomechanically probably something is wrong with these eyes. So we are really interested in looking at this group of patients, and I can tell you most of our collaborators, they try and collect these patients as well. Dr. Ambrosio has a huge number of form first cases. We had quite a few back in Hong Kong, and now have quite a few back in the United States as well. This group of patients will tell us whether the abnormality that we are unable to detect on Pentacam, for example, can we detect that on Corvis? So in the initial studies that we did using Chinese eyes, we found that Pentacam does very well when you differentiate normal and keratoconus. It's excellent. Corvis does very well normal from keratoconus. When it comes to form first, Corvis did marginally better than Pentacam. So the concept again is Pentacam detects a structural change on the surface of the cornea, but Corvis detects a change which happens probably before that, okay? And I use the word probably because that's all we know for now. And we actually found the Corvis is a bit better in picking up these cases. Now, importantly, this will also help us to a certain extent to understand how the disease develops. If whatever I said, it's true, then possibly biomechanical changes, they happen before the structural changes. Well, so the parameter that you're talking about is a combination of tomography and Corvis. We label that as TBI. We had a publication last year, and TBI did very well in detecting subclinical keratoconus, differentiating that from normalized. It's a perfect combination where you have the best of both worlds. You have the tomographic changes, you have the biomechanical changes. I personally have not seen a huge advantage of using TBI over CBI. It's really exciting. CBI for me works really well. But yes, there are cases when I really want to look at the TBI as well. So, as we talk, advances are being made. We're looking at more normative data. That's what we need really to see how TBI, if at all, differentiates or differs from CBI in normalized, in form first eyes, in subclinical keratoconus, and in fully blown keratoconus eyes.